Excellent. We are now very fortunate to hear from a set of our current investigators. I am sad to say that Steph Robert, who's on the program, is ill today. We'll post her slides, but she's not otherwise going to be here with us. But we're going to go right to Bill Buckingham. So thanks very much for coming.
So I am an associate scientist over in the UW Hospital in the Health Services and Care Research Program, working with Dr. Amy Kind. And we work a lot on neighborhood disadvantage in conjunction with Alzheimer's disease and other types of health conditions that we have researchers who come in and want to start to look at the social context around health. So what I'm going to talk about today is neighborhood disadvantage, health and aging. In particular, we'll talk a little bit about our work around the Neighborhood Atlas. So our overarching program goal is that we are trying to develop practical approaches towards eliminating AD health disparities. And really, we're looking at this nationally. This is not a local Wisconsin program. The construction of the ADI has been a national thing. And we're trying to create metrics that actually are applicable outside of even academia. We've had a number of groups who have come and used our data for program management purposes. And really what it all comes down to is geographic-based linkages of risk. So this is where I get to throw in my disclaimer. I may work at the hospital. I am not an MD. I'm a geographer. I'm the weird guy over there who looks at maps all day. So that's where I come to. It's really a unique group of people because we have statisticians, we have medical professionals and medical experts, and then you've got me as the geographer, kind of that idea of a transdisciplinary group. And so it's a fun group to work with, but our focus here with the Neighborhood Atlas and with the work that we're doing in the ADI is these ideas of geographic-based linkages of risk, so we're tying that together. So if we think about how does context impact our brain health, and if you've ever seen Amy talk, you've probably seen some of these images because I just borrowed liberally from what Amy's done. But places like this we've all seen, and you would think they look like places that would be areas where you would have good physical activity, where you'd be able to get outside, where you would see lots of a vibrant community. And so you would think brain health probably is something that you would have positive outcomes from in this type of environment. But what about this? What about an environment where we are seeing some type of economic disadvantage, where we're seeing some type of either socioeconomic or health-based disadvantage that comes into play, areas that are facing in poverty, low education, and all of those things. How does that impact brain health? And so that's kind of what we're trying to get at with this work around geography and health, is that we're trying to understand the linkage between context and brain health. So why do social determinants matter? So this is just a quick example of why social determinants matter. If any of you know the DC area, this should jump out. I actually went to high school just south here, so this all is very familiar, and you can see that around the DC area, Montgomery County, one of the most wealthy areas in DC, average lifespan, 81.3 years. Move over here to Prince George's County. Prince George's County, when I lived there, was a majority-minority county. So it was also one of the more impoverished counties in the area right around the district. And you can see average life expectancy here was only 75 years. A lot of factors go into that. But this speaks to a number of the reasons why social determinants matter, because we need to understand the context that's going into the lived environment that people in these areas, because this is not a big span of distance, and yet that's quite a large span of expected age that we're seeing. And you also could see this when we break down by race and gender. You can see that life expectancy by race and gender, there's a big difference here between if you are white or black, male or female. And so how does that lived experience come into play? And what does that look like going forward? So again, tying together, and of course, the nice thing is I'm speaking to a room full of people who have connections in demography, so none of this is a surprise to anybody, right? It all makes sense. When you talk to the docs, sometimes they go, oh, I didn't think about that. So it's kind of fun to come back and talk to social scientists. You guys get this. So the Centers for Disease Control talk about this health impact pyramid. These are the factors that impact health. And you can see that things like clinical interventions Protective interventions, these are things that are at the top of the pyramid, and yet with the work that we do in the med school, those are the things that we tend to look at. What are the clinical interventions that can impact health? But the entire pyramid is bound at the bottom by socioeconomic factors, something that is not typically looked at. In fact, I always think of it as, when I sit down and say I'm a geographer, they look at me like, why is a geographer sitting here? And then I sort of pull them along, and maybe it takes about a year, and then all of a sudden you see the light bulb go on. Oh, wait a second, I see why this matters. Now we can do this and this and this and this and this. And that's where they get to the bottom of the pyramid. They start to recognize that these socioeconomic factors, the geographic factors matter. And this is where they can start to then see how does this impact health going forward. So what we do over in the Health Services and Care Research Program, we're looking at dementia predominantly due to Alzheimer's disease, and how we're talking about how we see this disproportionate impact on racial and ethnic minorities and the socioeconomically disadvantaged. So notice we're trying to keep these separate, and you'll see this as we get into the ADI. We make an explicit effort to keep race ethnicity out of the ADI so that as researchers you can add that back in, so we're not double dipping on the race categories. And obviously you've long recognized that neighborhood disadvantage is a fundamental cause of health disparities. And this gets at, again, Tobler's Law, which I like to talk about because, as geographers, we only have one law, and that's Tobler's Law, which says things that are closer together are more linked than things that are farther apart. And so that's what we're finding is this idea of proximal health risks. If you live close to a health risk, your health is going to be impacted at a greater rate than somebody who lives farther away. Same idea as what Tobler talked about in just about every geographic context. So we know that living in a disadvantaged neighborhood is strongly linked to an increase in mortality and disease. We've seen that in a number of studies, including work that Amy has done, Lincoln Phelan studies. So that connection is pretty well established at this point. And we've even seen this in decades-long randomized controlled studies where we demonstrate that health improves significantly when you move out of a more disadvantaged neighborhood into a less disadvantaged neighborhood, even when your individual socioeconomic factors don't change. So you can see that this socioeconomic context is important when you have sort of a controlled study like that, people actually move away and there you see health change. So we know then that neighborhood disadvantage is modifiable, and it could serve as a potential target for that elimination of some of these health disparities. Now, I would not, even when we work with the ADI and construct this, it only accounts for about 50% of the variability. There's just so much variability out there. However, we know we can capture some of that with the ADI. And so what we're trying to drive at now is what is the impact of neighborhood disadvantage on the development of dementia? And we actually have an R01 grant that we're working on right now where we are taking a population who donated their brains to science, and we're actually mapping them back to where they lived all the way back to 1910 and constructing disadvantage metrics to try to understand how did their lived experience over time potentially impact their ultimate brain outcomes. And so you can see this is where I get to pretend I'm a doctor for a minute, an MD doctor. You can see here is these are two brains of 3-year-olds. On the left is a normal brain. This is what normal brain development should look like, and these are actually the same magnification. There's not a trick being played here. The right brain is someone who experienced severe environmental sensory deprivation. And so you can see the brain is smaller. There are larger holes in the brain, so you can see just from brain development that when you have some type of sensory deprivation, it has an impact on the actual physical makeup of the brain. And so this is sensory deprivation, but how does our contextual deprivation also play into that? And so you can see when you have mice that live in an enriched environment, they have more neurons. They don't have as many, their hippocampus layer is thicker. They're smarter. Their brain is healthier than the mice that lived in a deprived environment. And so we've seen this at the actual physical level as well. So what we want to do is we want to examine that association between disadvantage and baseline cognition. That's what we're working to get at. And so the way that where I come into this is from the neighborhood disadvantage side of things. So I've been involved for the last 5 years in the construction of something called the Area Deprivation Index. This was originally constructed by HRSA. Gopal Singh constructed this. He's published a few papers. And it incorporates 17 different measures, all drawn from the US Census. Of course, everybody here knows about the census, right? I don't even have to explain that one, which is fun. But education, employment, housing quality, poverty variables are all pulled together into this. And obviously, limitations mirror that of the census. And as we get into the ACS era, I get lots of people now who say, hey, can you do a 2017 ADI? Can you do a 2016 ADI? Can we compare them? And we have to go, not really, for the years overlap. So we've had to do a little bit of work, and some of the questions have changed. But in general, we're able to do this. So currently, we have 2 versions of the ADI out on our website. We have a 2013 version and a 2015 version. Now, you're sitting there saying, but you just said they overlap. That's no good. And you're right. But people wanted that pegged to the 5s and the 10s. So we have a 15 version right now, and 2020 will be out in a couple of years. And we are working at the census block group level, which is an improvement over what Singh was able to do. Singh was stuck at the tract level at the smallest, and most of his work was at the county level. His last ADI version was 1990. And so we have a couple of R01s that we're using to construct these and also to validate these measures. So what we've done is we've actually taken those block group level ADI values and we have mapped them to over 69 million zip plus 4 values. So we have this linkage so that you can actually connect those two. It's interesting, when you start talking about privacy concerns, the IRBs will say, well, you can't do this at a sub-zip code level, but you can do it at zip plus 4s. Does anybody know how much smaller zip plus 4s are to block groups? There are 30, 40, 50 zip plus 4s inside of a single block group. So it is sort of a concern from that regard, but these are completely anonymized, and when they're because we're dealing with census data, there's no health concern or no privacy concern in there because we're not working with the actual individuals. We're working at that contextual level. And so we incorporate, again, all of these metrics, and then we're able to predict disparity-related health outcomes using the metric. And so what the ADI provides is this nationally generalizable way to study impacts. So here's our typical geographic boundaries. Everybody knows what these are, right? The counties of Wisconsin. Big, coarse, not very good at telling us what's happening at the neighborhood level. So this is what we've come up with, is the block group level ADI. And one of the things that we've done, because we're using principal components analysis to produce the ADI, we just provide the rankings from least disadvantaged to most disadvantaged. At the national level, we provide an individual percentile ranking. At the state level, we move to deciles. So you can see some differences when you rank these between the national ranking and the state ranking. I'll show you some of that in a minute. So here's Milwaukee County. And if you've seen images of Milwaukee County at race, this looks pretty similar. Race is not involved in the ADI, so you can see this connection. Then you can actually then analyze race and the ADI in the same model. This is what the map looks like for the nation, excluding Alaska and Hawaii, which don't like to fit on a nice screen like this. This is what we've produced in conjunction with the POP Lab, which is where I spent the last 15 years of my time and before moving over to the hospital this past spring. The Neighborhood Atlas, and this is the website, neighborhoodatlas.medicine.wisc.edu. You can actually go download these data. You can actually work with the map interactively. And I'll run through this fairly quickly here. There's a quick download page that you have. You do have to sign up for an account just so we know who you are. But other than that, you can get data at the 12-digit FIPS or the 9-digit zip codes. The one catch is if you want the 9-digit zip codes and you want all 50 states plus Puerto Rico, you have to download those individually. They're just too big. They're gigabytes of data, and we just can't package that up in one nice package like we can the 12-digit FIPS codes. So when you get to the mapping component, you get to a site that looks something like this. You'll select a state, and then you zoom in. And this is completely interactive. You can hover over the different categories, and they will highlight on the map. You can zoom in, so if you have experience with Google Maps, you could be able to zoom in and explore, and you can then toggle this between the state-only deciles and the national percentile so you can see how they change. So you can see when I flip this, here's the national percentiles, and then the state deciles, it gets a little more red in Wisconsin, simply because in the deciles now, we're actually pulling out and highlighting the highs and the lows in the state, whereas nationally, those lows are a little more depressed. Menominee County sort of shows up, and that's the big one. You can zoom in. This is about the farthest you can zoom in, so you can get almost to the neighborhood level. You can see there's streets that are labeled there. You can navigate around without any trouble. You can also download the data and bring it into a GIS yourself. And so a couple of examples here. Here's the state of Maryland. So one of the things that led us to this idea that we had to do state only is because here's the state of Maryland in national percentiles. Looks pretty good, right? And that's what, when we were working with some stakeholders in the state of Maryland, they looked at the map and said, this doesn't look right. We know there are areas that struggle in Maryland, and this doesn't look right. And so when we recentered things onto the state of Maryland, this is what Maryland looked like. The Eastern Shore shows up. Prince George's County up through Baltimore now show up as areas of high disadvantage. So a major shift that happens. Likewise, here's the state of Mississippi in state-only deciles. Doesn't look too bad. I mean, it's, you know, a nice mix. But when we go to the national percentiles, and you can see this is how you highlight, but national percentiles, this is Mississippi. So it's completely red. And we've seen that what happens then is that areas like Mississippi, Alabama, and some of the other states that are highly disadvantaged, when you work at the national level, it just makes those states that are much better look like they're so much better, and we don't see the spread. So we've actually found in a lot of our work that most stakeholders are involved in looking at the national or the state-only percentages because they find those to be a little more useful locally, but then when you get flipped to the national, you get that sense of context of just what the spread actually is. So that's just a quick overview of what the work that we've been doing within the HSCR program around neighborhood disadvantage and our linkage then to Alzheimer's disease, which we are currently working on an R01 that is looking to look at make that linkage over the life course of individual participants. So that's down the road. Not a lot of preview on that yet. Still in early stages. So real quick, here's acknowledgments, just a thanks to Amy, Carol Herman, and Ryan Powell, who are our collaborators on this, and then to Caitlin Borbo at the APL, who produced the Neighborhood Atlas. It's fantastic work, so I encourage everybody go out and look at that. She's even made it mobile friendly, so you can all pull out your phones right now and start scrolling the Neighborhood Atlas, okay? Any questions?
Sorry, I forgot if you said how far back you're planning to generate these indices for.
So,
and when they will be available.
Okay, so that's two questions. One will have a good answer, and one we'll have to. We're not sure yet. So we'll start with the second one. We haven't decided because of the nature of historical census data. We're still working through what we're actually going to produce, and we're not yet convinced whether we're going to distribute those widely. It may be a research by research type of situation. Currently, we're going back to 1910. So we're pulling data all the way back to 1910. The problem you run into when you go back to the 1910 data, if anybody's looked back that far, is that there's mostly interested in agricultural census. And so there's a lot of data that is missing when you look at what we have for 70 and beyond. So 70 and beyond, I think we may be looking at release of those. It's when we get back farther that it gets a little more difficult. So that would be a few years from now before those releases would actually happen. Other questions? All right. Well, thanks to Jason for inviting me. I appreciate the chance.